professor in the School of Social Work at the University of North Carolina at Chapel Hill, and is a Wallace Peralt Early Career Distinguished Scholar. Dr. Lanier is a research fellow at the UNC Cecil G. Sheps Center for Health Services Research and the UNC Injury Prevention Research Center. He's received his doctoral degree from the Brown School at Washington University in St. Louis and was a fellow with the National Doris Duke Fellowship for the Promotion of Child Well-Being. Dr. Lanier's research focuses on developing, evaluating, and scaling up evidence-based prevention programs in child welfare, mental health, and early childhood systems. He's conducted externally funded studies with parenting support models such as parent-child interaction therapy and the Triple P Positive Parenting Program, Circle Parents, and several maternal and child health home visiting models. In addition to his focus on intervention research, Dr. Lanier uses linked multi-sector administrative data for policy analysis of childhood welfare and childhood health systems. He's currently a board member of the North Carolina Infant Mental Health Association and the North Carolina chapter of the American Professional Society on the Abuse of Children. Dr. Lanier, we welcome you. What a great bio. I'm excited to hear what you have to say on ACES. We're really excited. We reached out to you initially for summer school. So we're glad to have you on, and hopefully perhaps maybe the first of a few webinars. But again, welcome, and I'll go ahead and go into silence now. So.
Great, thanks so much, Robbie, and
Sure.
it's great to be here today to talk with everyone. I'm just going to imagine thunderous applause right now as I sit here in my home office with all the great people on the line right now. I'm going to go ahead and dive into this content. As you heard kind of from the bio, and I focus mainly on child well-being and child welfare. And so the first glance when I was thinking about this opportunity to talk about gambling and work with the Problem Gambling webinar series, my initial reaction was it was hard for me to see the exact connection. But as soon as I started diving into the literature, it was mainly my own ignorance. I think the overlap is very powerful, and hopefully you'll find the content useful to your work. Okay, so I'm going to go ahead and dive in, and hopefully technology cooperates. So I just want to say I have no disclosures at this point that I need to share, and these are my opinions and not of the School of Social Work or UNC. And at any point, folks, if you want to drop in a question or clarifying anything into the chat box, I'm totally cool with that. So what I'm going to do today is talk about the key findings and limitations of the ACES study, the Adverse Childhood Experiences study, focusing specifically on the burden on individual and public health. I'm going to talk about the best available evidence regarding the association between ACEs and problem gambling. And third, talk about some of the approaches and initiatives that we have here in North Carolina to address ACEs, and maybe we can think together about some overlaps with, again, a lot of the work you all are doing, either at the individual or maybe the broader public health level, to make this connection between preventing ACEs and preventing problem gambling more explicit, potentially. So a few concepts or definitions here at the beginning: social determinants of health, adverse childhood experiences, and third, just want to talk about the overlap between these concepts, these buzzwords we're hearing a lot about these days. So starting very broadly, social determinants of health, I think probably most folks have heard this term, but I want to couch the discussion about ACEs into this broader concept of social determinants of health, which are the conditions in the places where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So the conditions that affect our health. In the Healthy People 2020 definition, they kind of put social determinants of health in these 5 domains. And as we think about child adversity, you can probably imagine how they fit, different ACEs would fit into different domains of social determinants. So if we're thinking about child poverty, for example, that may be around economic stability. Exposure to child abuse, maybe that's the social context, things like that. Okay. I'll try not to get distracted with, yep, okay. So I'm going to cover a lot of studies and research today, but I want to just go back a little bit because, again, I imagine that the social determinants of health is, again, a term we're hearing a lot more of. And I just want to highlight the fact that this research is not really new, that we know that the conditions that people live in affect their health. Sir Michael Marmot from the UK wrote a book called Social Determinants of Health, which is excellent. One of their first studies looked at coronary heart disease among British civil servants. So think people who work for like the National Health Service, for example. And they looked at what place you were in inside that administrative structure. Were you an administrator, a CEO type, all the way down to clerical staff, janitors, etc. Right? We don't necessarily like to think of it this way, but there is a social order, a social hierarchy within large organizations, right? And so their question was, is there a difference in health if we look across these different strata of our organizational structures? And they found, yeah, for sure. So people in these administrative roles tended to have lower risks for coronary heart disease and a host of other health outcomes over time. And they wanted to understand why is that? So they looked at a lot of kind of the usual suspects we would think of in terms of like individual behavior or maybe genetics, like smoking, blood pressure, cholesterol, and then this unexplained. So these are relative risks, and inside each of these boxes are how much of the differences can be explained by various variables. So smoking, for example. And as you can see, when you get to the clerical and the other, at 2.3 and 2.6 are these unexplained things. And again, at the time in the late 70s, when the study was done, there was not really an explanation for what's going on that's making these people unhealthy. And they were starting to think about this idea of social determinants, just kind of our place in society. Today, a lot of the discussion around social determinants of health has centered on this pie graph on the right, where people are thinking about how to reduce healthcare costs and improve healthcare quality and get better health outcomes for the money we're spending. So as we know, the US spends more money than pretty much any other country on healthcare, but we don't get as good of outcomes. And this work looks at kind of the share, similar to Marmot's work, the share of health outcomes or premature death specifically can be attributed to these different things. And their finding, which has kind of been repeated over and over and over, is that healthcare is really only 10% of it. This is only 10% of the story. If we're going to be tweaking things in our healthcare system, that these other things, we maybe can't do much with genetics, but the social circumstances, environmental exposure, behavioral patterns, these are very important. We need to pay attention to them more as a healthcare system if we want to get better health outcomes. So in North Carolina, like many other states, there's now this renewed focus on, or a new focus on social determinants of health. Some of these you may be familiar with. So for example, our North Carolina Medicaid transformation efforts, which have been curtailed for a variety of reasons, included and highlighted social determinants of health in some of the policy changes. So for example, there's this statewide social determinants of health map, which you can see in the map on the bottom left. So you can look at each of your regions across the state and kind of see where across a set of indicators, I think it's a set of indicators, where the higher pockets of social determinants of health exist in your community. There's a set of screening questions, which we'll talk about screening for social determinants of health and ACEs specifically later, but there's a set of screening questions which are now available which at some point would be required of all Medicaid beneficiaries to be screened for these in addition to health screenings. NC Care 360, hopefully folks have heard a lot about this already, but this idea of connecting social care with healthcare is part of it. And then there were some healthy opportunities pilots, which would spend money on different types of services, not typically thought of as healthcare services, but that we know are very important to health. Okay, so that's kind of I think again, the bigger kind of picture of a transformation in our healthcare system that's happening due to our understanding and I think our research about what actually drives health. And ACES is part of that. So this is the CDC has been doing and leading a lot of the work in the ACES area. So this is the ACES triangle. You think about kind of what the mechanisms, how do adverse childhood experiences lead to early death? You can see at the bottom there is this foundation of generational and historical trauma, which can relate to greater adversity. Then the social conditions, right? That's social determinants of health relate to adverse experiences. And then we're going to talk about the neurodevelopment, social impairment, health risk behaviors, and then these health outcomes. So it's a good question. Do we want to think of social determinants of health, ACEs as a social determinant of health or a cause of social determinants of health? It doesn't really matter. They hang out kind of in the same area to me. So to me, I think of ACEs as a social determinant of health that is also driven. It's a very dynamic process. Okay, so the CDC Kaiser ACEs study, again, I hesitate to get too much in the details because I think a lot of people have heard a lot about this study, but it was a large study of about 17,000 members of the Kaiser Health Plan, and they did a survey where they asked people about this set of these adverse childhood experiences, these ACEs, so emotional abuse, mother treated violently in the home, an incarcerated relative, physical abuse, mental illness, emotional neglect, divorce, sexual abuse, physical neglect, and substance abuse. They call it substance use in the home. And the study, was generated. The impetus for it was it was an obesity clinic. So, and they had a group of patients who would do well for a while and then regain weight. And so they started thinking, well, we need to understand more about the patient's history. And time after time, there was discussion of childhood trauma as being a major barrier to their recovery with obesity. And so that's what kind of prompted them, the Kaiser doctors and the CDC, to say, well, let's study this on a more broader population level. And study after study, paper after paper, when they looked at the number of ACEs, the number of these adverse experiences, there is a stair-step, clear, dose-dependent relationship with essentially any negative health outcome you can think of. Again, these were adults retrospectively saying, how many of these things happened to you? And then what's your current health status? And again, kind of this stair step, the more ACEs you have, the worse their health outcomes. In terms of the research literature, we see this explosion in papers, in the last 10 years or so on the ACEs topic. The idea of trauma and stress affecting health, as I'll mention soon, that's not new, but this conceptualization of ACEs is a newer thing in the research literature. This is kind of the first major landmark paper, this Felitti and Anda relationship of childhood abuse and household dysfunction to the leading causes of death. One cool thing I like about the ACEs research is that it is pretty multidisciplinary. It's not kind of like one specific area. So here's just kind of where all the papers are across. So I'm in social work, but you've got psychiatry, pediatrics, a lot of different disciplines. And again, I think it's exciting for me at least to have another kind of new area of behavioral health in terms of gambling disorders to think about how ACEs, interact with that outcome. So how do ACEs or adversity, how does it affect our health? The mechanisms, I want to get into that just a little bit. So there's been a lot of research and work on some people call it developmental traumatology. Okay, So I see there was a hand raised, but if you want to chat, type in if you have a question. Let's see. I don't see any questions right now, but I'll try to pause if. Okay, 2 hands raised. Let me stop for a second. If there's a question or maybe there's something possibly wrong with the technology. Is everyone still hearing me? Okay. Yeah,
Yeah,
go ahead.
yeah, I can hear you, Paul. Let me see if I think it was Brenda and someone else had raised their hand
Yeah.
too. Yeah, if you guys want, of course we can try to get to you, but it might be quicker, at least at this point, to chat us. Let me see if I can find them right here. Where is Brenda?
Raised by accident. Got it.
Yeah. Okay.
Thanks,
Cool.
Brenda.
All
No
right. Thank you,
problem.
Brenda.
Okay,
Yeah.
I'm going to keep rolling. So again, this field of kind of developmental traumatology, really getting into understanding the neuroscience of how does adversity affect brain development. And so there's been a lot of work on that. And this researcher, Bruce Perry, has looked at, again, the brain development. So actual, like the differences in the size and architecture of the brain when you compare 3-year-old children, in this case, normal, quote unquote, to those who've experienced extreme neglect. And again, so a lot of this, some of this research predates the adverse childhood experiences studies, but we have known that abuse, and even in some cases more so neglect, completely changes kind of normal brain development in children. And so we know more about how when those brain pathways are altered, it can affect behaviors, specifically around emotional regulation, stress response systems. And by the way, Bruce Perry, people often ask, like, what are good recommendations for books? Boy, I will type in who was raised by, I'm not getting this exactly right, but this is a great book, Boy Who Was Raised by Wolves, or by a Wolf, something like that. Really, really cool discussion from Dr. Perry about his experience as a psychiatrist working with kids who've been traumatized, and how we respond to them in practice, psychiatric practice, mental health practice specifically. Okay. Again, just want to, when we're talking about adversity, a lot of times we're talking about, thank you, dog. Thank you, Cindy. That was close. We're talking about our stress response. And you could think, again, for a shorthand, like fight or flight response. And this is not something that was just discovered with the ACEs literature. In fact, this goes back to 1936, Hans Seil's letter to Nature about general adaptation syndrome. I found a nice picture of Hans, and pointing out how stress affects, again, I think that's a chalkboard. I haven't seen one of those in a while, but this HPA axis, the brain and the different hormonal systems, neuroendocrine systems in the body, in the gut, different parts of the body. So we've kind of had some evidence that stress can get under the skin, quote unquote. Yeah, Bessel van der Kolk, thank you. Yep. And so this is from 2013, and I just point this out to show that, almost 100 years later, we know a lot more about the details of these hormonal systems and how they impact the body systems and how the processes work. But the general idea that the stress we experience and our outside lived experience and our perceptions of that stress can go through our brain into our body systems. This is another fairly recent one. Again, my interest is specifically in child abuse and neglect. But again, I'm not going to spend a whole lot of time on these details, but how acute psychological stress, in this case, this little picture of a child being, looks like verbally abused by a caregiver, can affect brain systems and then actually affect how we respond to injuries or infections, our immune system overall. And then over here on the right, new research around gut dysbiosis, like how our bacterial levels in our gut affect things like obesity, substance use, poor sleep, psychopathology. So we're learning a lot more about these mechanisms for sure. And there's Hans in there again. Some other things to think about in terms of pathways and mechanisms. We talked about brain development. We talked about dysregulated stress response. Behavioral pathways, right? So these are all connected to each other, but how do you get from adversity to poor health? Well, increased risk for substance use, obesity. This is a review of the literature from this paper. It wasn't in there. Again, I've added just basically based on what I've been reading in the last month or so about this topic. Problem gambling is being another behavioral pathway, how you can get from child adversity to this poor health outcomes. There's social pathways. So people exposed to trauma in childhood have different interpersonal styles. They're higher risk for re-victimization of violence, higher risk for homelessness. They have impacts on cognitive pathways, so how we think about our health, how we think about ourselves and our relationship with the world is completely altered oftentimes when you've experienced childhood trauma. And then of course, emotional pathways, depression, PTSD is more likely to occur if you've experienced trauma in childhood. Overall, this is a really good, I think, summary in the Lancet about the associated costs of ACEs. This one was across Europe and North America. So putting all the studies together, what can we estimate the costs are? So each year in the US, $581 billion, in Europe, $748 billion in North America. Then they go on to say that just reducing ACEs by 10% would save $105 billion. I like putting the zeros out there just to remind ourselves that's a lot of money. If the financial costs are your thing, it's helpful when talking to policymakers. I don't find it as compelling. We should probably try to prevent child adversity because it's the right thing to do. Okay. What do we know about ACEs and risk for gambling disorders? And again, I want to apologize if I get certain terminology wrong. I'm not using the right terms. I made an effort to get up to speed on it as much as I could, but I realize there's some nuance in the language. I'm going to talk about 3 specific studies, but overall, in reviewing the literature, there's some pretty good evidence regarding specific trauma exposure. So if you want to look at child abuse, for example, there's pretty good research evidence that shows a greater risk for developing gambling disorders if you've experienced child abuse, or among those who experience child abuse, the risk is higher. You see evidence about PTSD symptoms, gambling disorders. There's not a lot about ACEs broadly. Again, I think that's probably because this is a newer terminology, so we can kind of retrofit this into prior research. I think we've known about it, but I found 3 pretty good studies, I think, that use this ACE terminology specifically. If you want these, by the way, and you're not able to access for, you're behind a paywall or something, please email me. I'll be happy to send them along. This first paper, Sharma and Sacco, used data from NESARC, which some folks may be familiar with, National Epidemiological Survey of Alcohol and Related Conditions. This is our best nationally representative study of behavioral health outcomes, specifically substance use, alcohol disorders, and related conditions. So they use this measure. So it's an interview schedule, which I think is important when looking at research. It's like, how were these things measured? So like asking someone, do you have a alcohol use disorder, versus going through one of these interview schedules connected to the DSM. So that's what they did here. In the NESARC, they focus specifically on abuse and neglect. So, if they didn't ask about all those other things, is this really ACEs or not? We could, debate that, but they focused on abuse and neglect specifically. Okay, and then they looked at, so this is first kind of the bivariate associations, and hopefully folks don't mind digging into the research here a little bit. So the first groups you would want to look at is the NG, the non-gambler, and non-problem gamblers. You look at something like physical abuse, something like 4%, 5% experienced physical abuse. If you go over to problem gambler and pathological gambler, you go up to 7 and then 12%. You've got your p-values over there showing there's a statistically significant difference. So be comparing a non-gambler to a pathological gambler, you've got probably, it's about a threefold increase, at least at this bivariate level. I think an important thing to point out here, though, is that among folks with problem gambling disorder, 12% experienced physical abuse. So we want to be careful about not kind of overextending findings to be about every single person, where you'd say, well, everyone with problem gambling has been abused as a child. That is obviously not the case. If you've been abused as a child, your risk is higher for developing this and many other disorders, but it is not deterministic. ACEs are not deterministic. Very important point. In fact, they found, the other finding when they put all the stuff in one of these multivariable models, ACEs were no longer significant when you control for mood, anxiety, and substance use disorders. So there's maybe some evidence there that, at least this study, the pathway may go in more to these kind of emotional disorders and then more into gambling disorders, potentially, which I thought was kind of an interesting study. Paper 2, which comes from North Carolina data, this BRFIS data, which I'll talk about more. First, state-specific BRFIS study to use a problem and pathological gambling screening measure, which I thought was interesting. And the high-risk group was identified by loss of control, lying about gambling, and preoccupation with gambling. And so again, here we're comparing problem pathological with low-risk gambler. Again, this is a study from North Carolina, which I think is kind of cool. And there are ACEs at the bottom. So problem, they just added them up. So how many ACEs did you experience out of the 9 or 10 they included in this study? So about 2 for problem pathological, 1.4 for low-risk gamblers. Statistically significant. You can kind of look at the effect there and how large of an effect you want to think that is. They said, just yanking this straight out of their discussion, clinicians may benefit from this study by prioritizing the assessment of ACEs and externalizing disorders in individuals presenting with problematic gambling. So assuming there's some clinicians on the call right here, this is their how they would interpret and translate these findings, that this may be something that you would want to assess among individuals presenting with problematic gambling. Okay, paper number 3 in a random red box. I got my stuff out of order here. This is a sample of community gamblers. They completed a self-report measure using MTurk, which I won't get into a lot. So it's basically like a sample they've got from online. So some folks think that you get more honest assessments sometimes using these types of approaches. And they found, comparing non-problem gamblers, I can't say gambler apparently, to problem gamblers, there were more total ACEs in the problem gambler group. So among non-problem gamblers, 4 or more ACEs was about 28%, and then problem gamblers 50%. So half of problem gamblers had experienced 4 or more ACEs in childhood, which that's a pretty large proportion. I like this conclusion from the paper, from the articles pool. ACEs as historical events cannot be changed. Emotional dysregulation can be improved. So the other thing they looked at is, again, the mechanism. What's the mediating role of emotional dysregulation? So we're trying to figure out, like, what's really going on. I can't change the fact that you experienced childhood abuse as a child, right? Where do I want to focus as the clinician? Again, they find evidence that it's through this emotional dysregulation. Again, going back to the neuroscience information that I just kind of glazed over there, we know that there's some things happening in our neurobiological systems that are impaired among folks who've experienced adverse experiences. So how do you get to gambling severity there? Well, it's probably through those emotional pathways. This is a paper specifically on, or more broadly, on substance addiction. And again, I was fairly struck at how similar, maybe this is something you see all the time in gambling research, that the mechanisms seem to be very similar to other types of addictions. And this paper kind of goes through the dopamine, oxytocin, glucocorticoid systems and how they're affected in the body. And again, I would imagine you could overlay the same kind of, these same pathways that we see in substance addiction more broadly onto gambling. I'm sure there's unique things as well, but at least to me, my read of the evidence so far shows that there's some parallels and similarities in these mechanisms that we know more about in substance addiction than it appears we do in gambling disorders. Okay, so hopefully I've convinced you all, for the most part, that we understand why ACEs impact our health, why they're probably related or seem to be related with gambling disorders and behavioral health conditions more broadly. Let's talk a little bit about what is the prevalence of ACEs in North Carolina. Just in the interest of time, I'll try to move through this relatively quickly. We have two data sources. Again, the BRFIS and the National Survey of Children's Health. It's important to have the distinction between these. So in the BRFIS, you're asking adults to think back to their childhood, 18 to, I think it goes up to 65 maybe. So people on the call, you're thinking back, tell me about things that happened in your childhood. You can imagine some of the limitations of that, considering we don't really form memories until 2, 3, 4 years old. We're not going to remember a lot of things that happened in infancy, etc. So there's some issues with memory and recall in general. National Survey of Children's Health is asking parents about their kids now. So tell me about your child now. Have they ever experienced a parent dying? Have they? So there's a little bit, it's a little bit closer in terms of the time frame of when things are happening, but you have a parent who's reporting on the experiences of their child. Limitations there for sure. So we don't have, it's a hard thing to measure. It's a hard thing to study, no question. They measure slightly different things. So in our ACEs, there's still debate in literature about what is an ACE, what should be considered. So National Survey of Children's Health does not include these with the X's on them. BRFIS does. National Survey of Children's Health adds these 4. So racial discrimination, which I think is on a lot of people's minds in terms of race equity these days, they include that as an adverse experience, children experiencing discrimination. So once again, I've severely misestimated my amount of time that I would take to get through this. So I'm actually going to skip ahead some. These next set of slides have each of the ACEs broken down by race ethnicity for North Carolina. Right, so you can kind of see the overall levels. I'm going to skip to the summary slide. You can go back and look at these in more detail if you want to. I am going to stop here to make this one point. This is from the National Survey of Children's Health. On the bottom axis, you have child age, and you've got 3 different lines there. So you can imagine that over time, from infancy to teenage years, just because you're experiencing life, you're going to experience more adversities, right? So the line's going to go up. This is the percent of children who've experienced an ACE up through age 18. The blue line in the middle is kind of the total overall. It starts down around 25%, and by teenage years, over half of kids have experienced one of these adversities. However, I think what's an important thing to consider, again, in light of our efforts to improve race equity, especially health disparities among Black folks in North Carolina, is that by age 3, half of Black children have been exposed to at least one ACE. You have to get all the way to age 17 until half of white kids have experienced an ACE. Right, so 50% of Black kids by age 3, 50% of white kids by age 17. To me, this is pretty startling. Hopefully, if you don't take anything else away from this, the burden of ACEs is definitely greater among Black African American kids in North Carolina and nationally. But overall, I'm going to skip to my summary slide here. Again, you can go back to it. Across our two surveys, this is, again, the prevalence, and these numbers are not disaggregated. So if you go back, you'll see higher rates for many of these ACEs among Black African American children. We're not looking at the differences across economic strata as well. But overall, whether you're asking an adult retrospectively or you're asking the parent to report on a child, we have what I would consider to be fairly high prevalence of ACEs in North Carolina in general. These same BRFIS data, again, we saw before, were related to and associated with risk for gambling disorder. And again, pretty much any health, behavioral health, societal outcome that you could come up with, there's probably a study that shows the graded response with more ACEs. At the very bottom, the total ACE score. So in North Carolina, about 60% of adults have experienced at least one ACE. In that National Survey of Children's Health, again, 35%. Keep in mind it's lower because you've got a bunch of 1- and 2-year-olds in that sample, and maybe they have not yet experienced the ACEs that they will likely face during childhood. Okay, so I want to talk some about the limitations of translating ACEs into practice. So let's be critical of the literature. We don't have a good definition of ACEs or adversity overall. We've got different things we include in there across studies. We mainly look at these binary categories, like did it happen or not. Folks are not looking at severity, timing, duration of ACEs. Why these 10 Kaiser CDC ACEs? Now they've been kind of replicated and people are using the same ones over and over again. Maybe these are the best ones, maybe not. There's plenty of studies that show when you use other ACEs, you have some increased validity. It assumes each adversity is equally important. There's some evidence to support this, that maybe our body stress systems don't really know if it's divorce or you're witnessing partner violence between your parents, you're just stressed out. I think that there is also some research and some logic to the idea that different adversities will take a different emotional toll on your body, your stressor system, and just how we perceive them are different. Okay, and there's some more of these. So, and I'm going to skip through this. This is basically another study just showing the differences between if you measure these ACEs prospectively versus retrospectively. So it's, again, some pretty major issues in terms of relying mainly on recall from folks' memory about whether or not things happened. Okay, I want to talk about resilience because ACEs is completely from a perspective of risk or maybe a deficit perspective. Again, we also have really good evidence that most people who experience adversity don't end up experiencing early death or these behavioral health issues. So to me, the evidence is yes, ACEs are bad because they hurt our health. But to me, the other story here is that we have a remarkable ability as human beings to overcome bad stuff happening. Like kids and families and communities are amazingly resilient. I think we're all seeing that right now. And the reason we're resilient is largely because of protective factors, right? These are our shields against the risks of ACEs. You know, you often see, this is a pretty commonly used ACEs framework, you know, thinking about the soil and, you know, the metaphor of humans as being plants. But again, I want to, you know, remind folks that it's not like resilience is this thing where this plant grows up in the middle of a desert or whatever. We're social creatures. And again, our resilience comes from our social connections. That is where our resilience comes from. The protective effect of strong relationships with our parents, our caregivers, other adults, peers, siblings, communities, etc. In general, though, for a definition of resilience, there's been a lot of work on this recently. It's basically overcoming the odds, right? So if we take a lot of, big sample of kids who've been maltreated and we plot their psychosocial functioning, we get this, regression or trend where we'd say, okay, if you have a maltreatment severity of 2, we expect you to have lower psychosocial functioning on average. That's just kind of what's expected. But that kid there at B is an outlier, right? They've risen above what's expected. And so, by some of the definitions, we consider a resilient child. Kid A up there, he's had great parents, no maltreatment, and they're successful. Again, that's what we expect. They're not resilient, quote unquote. So we're still trying to figure out some of these definitions, but this is one more recent one that I think is useful to conceptualize resilience. And resilience, just like adversity, is multi-determined, right? So my work hangs out a lot of this family support, environmental level, like how cohesive our society is, what are our cultural resources. All those things are important, but keeping in mind a lot of this is happening, internally. This is happening on this biological and even genetic level in some ways. So in terms of the research, we're trying to hold both of those bigger kind of environmental and policy things happening at the same time as our body systems are responding to that environment. Okay, so overall, what have we observed about ACEs through these studies? One, we know there's what most people would consider a high prevalence of ACEs in the general population. Most people tend to be surprised, maybe it's not surprising to you to see that half of people have experienced one of these ACEs. We've also seen the highest exposure in vulnerable populations. In this context now, African American, Black children have a higher burden of ACEs. I think we've supported this causal link between ACEs and poor health over and over again. We see evidence for that. So to me, maybe this corollary is that if we prevent or buffer ACEs with protective factors, we can promote individual health and we can probably reduce health disparities. So that's cool. In the field though, how has the field translated this into interventions? Well, overall, I think there's been more awareness of it. Like the fact that you asked me to talk to you all day, I think is one indication that this is on more people's radar. There's more screenings of this movie Resilience, for example. Maybe you've seen that in your community. More people talking about this. That's good. That's a good thing. I think more people are advocating for evidence-based policies and programs. That's cool. We'll talk about a couple of those in a minute. The third one is the awareness of ACE score in service delivery settings. And we saw that in one paper that they said clinicians may want to think about assessing for ACEs. And that has kind of translated into, Oprah's talking about it. Nadine Burke-Harris, who's now the Surgeon General of California, are talking about ACE scores and screening. And then folks want to make this leap to ACEs being a vital sign. And this is where we need to have some conversations, I think, about translating this evidence. So this is, a little bit of a silly example. Maybe it's not. Do we imagine that one day on our, we're in the operating room and we've got our vital signs and then there's the ACE score. Maybe that's a good thing. Maybe that's not a good thing. Or maybe your lab test results. You've got your white blood cell count and then your ACE score is on there. We're going to medicalize ACEs, right? And so in California, the plan is to screen all kids for ACEs. So again, imagine what that would look like in a clinical practice. Again, in North Carolina, if we screen all Medicaid beneficiaries for ACEs, adults and children, what that would look like. A couple of researchers are kind of asking for folks to maybe put a pause on this. So David Finkelhor, who's a top scholar in this area, is suggesting that it's premature to start widespread screening. We don't have effective interventions and responses There may be downsides or unintended consequences of screening. And then more recently, Dr. Anda, so one of the CDC Kaiser investigators, is saying, under the type of guidelines employed by the United States Preventative Services Task Force, the extension of ACE-related risks from epidemiologic studies to individuals using their ACE scores for the purposes of individual screening and clinical decision-making is not appropriate. Okay, this is obviously something, evidence-based practice, you have to take the evidence as well as your clinical expertise and your patient preferences and or client preferences into account, of course. But we've got some folks saying, yep, screening, we need to screen everybody, and some folks saying we're not in a position to be doing that. And here's just some data, like, is our health system really ready for that? So this is from North Carolina. And again, across the board, if we look at, do you get quality of care? Do you have family-centered care? Do you have a medical home? Are you getting mental health services when you need them? Kids with more ACEs tend to have worse quality of care. So if we're going to be screening these kids and identifying them, then we have some work to do in our healthcare system. Okay, I like this. So this is a practitioner review, and this is what they say. In general, only routinely inquire about ACEs where the benefit outweighs any potential harm and where evidence-based interventions exist and are readily available. So in North Carolina, so in general, my thoughts are maybe we hold off on universal screening for now. Let's focus on preventing ACEs, prevention of adversity, and make sure that there are more evidence-based interventions. So in North Carolina, we've got Prevent Child Abuse North Carolina. This Connections Matter is one of their campaigns right now. So just thinking about, again, more kind of universal prevention is maybe a useful thing. And then, so more for kind of treatment, we have interventions. One for kids is called young kids, attachment and biobehavioral catch-up. And so if you are working with young children, I recommend you check out the North Carolina Child Treatment Program. They have a host of evidence-based, trauma-informed treatments you can look up in your community where those are offered. We need more of these. We need more funding for these programs. We need more clinicians trained in these evidence-based interventions. And then for working with adults, obviously no way to cover everything, but I just put this up here to show there's a range of interventions for adult survivors of ACEs. There's no gold standard, and this is just half the list on the right. A lot of things you are probably familiar with, a lot of mindfulness-based stress reduction, cognitive behavioral therapy, expressive writing are pretty promising. Okay, and it sounded like I heard, at least in the introductions, these types of modalities, trauma-informed interventions being more available and getting training on those. So that's good. So there's good news. Okay, I didn't leave a bunch of time, which I apologize for, but that's a quick overview of ACEs in general, kind of where we're at in North Carolina and where I think the field is in terms of translating this research. I'm happy to take any questions or comments at this point. Let's see. Yeah, sorry about the going quickly. It's one of those things of trying to get as much information available in the slides so you have them. But absolutely, I think you all have access. We'll make sure you definitely have access to it, and I'll share any of this information for sure.
Yep.
So sorry about that, Atisha.
Yeah, sorry, Dr. Lanier. I forgot in my announcement, guys, the recording will be on the UNC Behavioral Health Springboard website along with the slides. So this will all be available to you. And I thought your timing was great and everything that you covered was great. If I may real quickly, I love the connection you made with the simple connection of resiliency with relationships. I liked what you said about that. And the big take home for me was that one slide that you moved too quickly with the ACEs by the age of 3 with the Black population, African-American population versus, was it the age 17 Caucasian, right?
Yep.
So,
Yep.
yeah. So does anyone have, we got a few minutes here, if you have any questions for Dr. Lanier.
Please discuss the meaning of the term externalizing disorders, is one that I see here. And so in general with children's behavioral health, we separate things into externalizing and internalizing disorders. So externalizing would be, your conduct disorders, things like that. Internalizing would be more your depression, things like that. And that was 30 minutes ago. Sorry for not answering it then.
Looks like you're getting some thank yous and some
Oh.
praises. Any more questions for Dr. Lanier while we have him? You've got 4 minutes. Do you see that one? Paul, someone was asking about conduct disorder.
Yeah, I saw that. Well, I see one more about resilience programs available. Please speak more about resilience programs available. Let's see here. So resilience programs available. So there are a few different levels I would put that at. So at the community level, there's been a lot more emphasis on developing community-based resilience initiatives. So through our North Carolina Partnership for Children and Prevent Child Abuse, North Carolina, and other groups, there are specific kind of interventions where they bring a community together. Off the top of my head, Robeson County's been working on this for sure. And so they bring a lot of community members together and say, what can we do to improve the resilience of our community using this very or fairly structured process. So there's stuff like that. At the individual level, there are interventions or programs for youth and for adults that are trauma informed that try to address trauma that youth or adults have experienced to help build protective factors to show resilience. That's how I think of it. So when you say resilience programs, there's a large swath of things that I would put in that topic. Any benefits in the universal ACEs testing? I think that there are benefits to universal ACEs testing if you are in a health and behavioral health system that can provide services to your clients' patients, right? The Center for Youth Wellness, which is Nadine Burke Harris's, the clinic in California, they have this amazing integrated care staff with, social workers and clinicians, as well as, the pediatricians and doctors, and just an array of interventions. And then if I'm sending my kid to that clinic, then yes, screen away. That's great. If you are at another setting, if you're in another setting that doesn't have resources, and you're going in and say, hey, kid, tell me, were you sexually abused? Tell me, did your parents die? I'm concerned about re-traumatizing kids, and there's some decent evidence that happens in about 5% of the cases for people who have experienced this, doing screening, and you don't have someone there to attend to it. I don't see the benefit of doing that. So it depends on the setting for what we call universal. Everyone in North Carolina right now, I would not be in favor of that. Being raised in a home with a problem gambler at center age, that's a great question. And I looked at the language again, and the ones that I saw, they do not use that word specifically. They would say someone with a severe mental health disorder or a substance use problem, or someone who has attempted or committed suicide, something like that is the language. But that's a great example of something where we don't have that in our measure currently, but you can imagine if you were a child in a home with problem gambling, you're probably experiencing some adversity and you're completely being ignored in those measures. Nationwide effort. Yeah, prevention of childhood nationwide. Yeah, Prevent Child Abuse America. That's kind of their thing. So they're trying. Let's see. ACES tool. Yeah, so the ACES tools, if you mean by an ACES screening tool, there's a couple of those online. CDC has one, Center for Youth Wellness. And in that Medicaid screening tool, if you've seen that from North Carolina, in the back, there's a set of additional, so they didn't require the ACEs, but it's optional. So it's in there as well. Email me if you want some more help with where to find those resources. Yeah, I like that, Cindy. Yep. And as you can see, this is, I mean, that's why I love this topic. There's so much to talk about, so many layers to this. It's something I think everyone can resonate with on some level, whether you've experienced this or know someone has. We understand the idea of the things that happen to us will impact us down the road, in good ways and in bad ways.
Yep, and we're a minute past the hour. And Dr. Lanier, we would like to thank you. Thank you for getting those questions, man. You were efficient.
Yep.
Yeah, thank you very much. And there's Dr. Lanier's email address. Again, we want to thank you. And I personally, I love the heavy academic research approach to connecting ACEs to problem gambling. And where I'm at in my learning curve, this was great. So again, we appreciate it. If you guys would like the recording, again, it'll be on the UNC Behavioral Health Springboard website. The slides will be there as well. And please tune in July 23rd with Dr. David Ledgerwood. He'll be speaking on psychosocial treatments, motivational interviewing, and cognitive behavioral therapy. Thank you very much, Paul, and everybody have a good, well, we're right in the middle of summer, so everybody stay healthy, and thank you. Thanks again, Dr. Lanier.